right, the anterior slide test, you're going to have the patient have their arm go across their hip with the thumb facing posteriorly. You're going to come behind them, you're going to support them, and then you're going to apply an anterior superior force on the humerus, and they're going to resist. So Corey, I'm going to apply a force on your elbow.
Okay.
I want you to resist me.
All right.
So any pain or clicking is a positive test. Pain in the anterior superior region of the shoulder is also a positive test, and just a reproduction of their concordant sign in general is a positive test, possibly for a SLAP lesion. The next test is going to be the empty can test. Empty can test, you're going to be testing for supraspinatus impingement or supraspinatus tear. So you're going to passively elevate the shoulder and the scapular plane. You're going to internally rotate the shoulder, and you're going to apply a downward force. Don't want to move your shoulder. All right, relax. Positive test is pain reproduction in the shoulder region, of course, with the supraspinatus tendon. Next test is the near test. You want to have a seat for me? Come around. And the near test.
Oh, my nose is itching.
You're going to passively elevate the patient's arm in the scapular plane. You're going to move to in range. You're going to then apply overpressure in the direction in which the angle in which you raise the arm, so in the scapular plane. You're going to then internally rotate, apply overpressure. You're going to then externally rotate, and then apply overpressure. Pain with any one of those movements is a positive test of the rotator cuff. Could be a rotator cuff impingement, subacromial impingement on the coracoacromial arch or the superior rim of the glenoid. The next test is the supine impingement test. We're going to get you to lay down. And the supine impingement test is not a diagnostic test, but a negative test, meaning no pain reproduction, will indicate that there's probably not a rotator cuff pathology going on. So you're going to passively elevate the patient's shoulder to in range, about 170 degrees. You're going to externally rotate. You're going to adduct. Then you're going to internally rotate the patient's shoulder. A positive test is pain reproduction. And again, a negative test is going to rule out rotator cuff pathology, more so with this test than it ruling something in. The next test is the apprehension test, and you're going to be testing the passive restraint mechanism, the anterior instability, and you're going to have the patient in 90 degrees of abduction, 90 degrees of elbow flexion, and you're going to externally rotate the patient's shoulder to in range. And as you apply overpressure, you're going to get a sense of apprehension of the patient. It's not a pain reproduction, but apprehension, then you know that there's possibly some anterior instability. The next test is the anterior release test. It's also an apprehension test. You're going to have the patient's shoulder in 90 degrees of abduction, 90 degrees of elbow flexion, and you're going to support the patient's elbow with your thigh. And as you rotate externally, you're going to apply a posteriorly directed force into the glenohumeral joint, and that's going to prevent the anterior migration of the humeral head. But once you get in range, you're going to release your posterior directed force, and if they have a sense of apprehension, then that's also going to mean they may have some anterior instability of the joint capsule. So the next test is the elbow test. So Corey, why don't you go and stand up for me? The elbow flexion test, you're going to be testing for cubital tunnel syndrome, the ulnar nerve. So make sure they are standing up straight first of all. Corey, I want you to reach towards the floor with your arms straight. Now I want you to flex your elbow up. And I want you to turn your palms outward. And I want you to bend the wrist back. So that's putting the ulnar nerve on stretch. So a positive test is going to be numbness or tingling along the ulnar nerve distribution. So the medial part of the hand, the fifth digit, or the medial part of the fourth digit is a positive test. So we're going to sit here for 35 minutes. All right, 3 to 5 minutes. So then the next test is going to be a valgus stress test. So we're going to support the patient's arm fully, so relax a little bit. You're going to palpate the joint line, medial lateral epicondyle. The forearm is going to be in full supination, and then you are going to apply a valgus force to the elbow. And if you have any extra play in there or pain reproduction, then that could be UCL tear or UCL weakness. Next test is going to be the Mills test, and you're going to be testing for lateral epicondylalgia or tennis elbow. So you're going to palpate lateral epicondyle, and then you are going to flex the elbow. You're going to pronate the forearm, and you're going to flex the wrist, and then you're going to subsequently extend the elbow. That's going to place the extensors on stretch. And if there's any pain reproduction in the lateral epicondyle area, lateral elbow area, then that could be possible indication of tennis elbow. The last elbow test is the bicep squeeze test, so let's have a seat. The bicep squeeze test, you're testing for a distal tear of the biceps brachii. So you're going to place one hand across the belly of the biceps, and the next hand is going to be at the musculotendinous junction, and you're going to make sure they're in pronation first. Because as you squeeze and they're relaxing, the forearm is going to move into supination. So if they have supination as you squeeze, which mimics a contraction of the muscle, then it's a negative test. But if it's a positive test, they won't have any signs of supination.